So, welcome to this episode of Menopause Conversations. I'm delighted to have my next guest with me, who we bumped into in person, didn't we, at the Women's Health Concern? I think it wasn't last year, it was probably the year before. And I saw a post on LinkedIn and I thought, oh, this is the right time to get the fabulous Kate Pleace on. Hi, Kate, how are you?
Hello, Amantha. Lovely to talk to you again. And yeah, I can't believe that's 2 years ago. But I
I know.
remember I was literally leaving and we bumped into each other. So,
Yeah.
God, time's flown by.
I know it's absolutely flavor. So let me tell you a little bit more about Kate, and she will tell you more about herself too. Because today's conversation is all about navigating fertility, primary ovarian insufficiency or POI, progesterone hypersensitivity, all of which Kate is someone who's incredibly knowledgeable about and has a working knowledge and far more than that. So tell us a little bit about you, your role, and how it is you find yourself talking about just some of those things that I mentioned before.
So I'm a specialist women's health nurse. I've always worked in the area of women's health since I qualified as a nurse, which is nearly 20 years ago. So, oh
Wow.
dear, time is flying. I moved into working in fertility quite closely, working in a fertility clinic, managing an egg donation program, supporting patients having IVF cycles. And it was during when I was working, particularly in fertility, that my own personal journey with infertility and POI kind of became intertwined with my working life. So I'd already been working at a fertility clinic when I'd met my new husband. We'd got married and decided we'd like to think about having children. And then all of a sudden, kind of the two paths were a little bit blurred. So I was a fertility nurse who also became a fertility patient. Husband and I had a couple of IVF cycles. We went through all the fertility investigations that patients routinely go through. And then I was diagnosed with premature ovarian insufficiency or POI, which is when you experience menopause symptoms and your ovaries don't function as they should before the age of 40. And this meant that with regards to treatment, the best chances of trying for a family would be using egg donation, so donor eggs, where a lovely lady donates her eggs and you're able to use them in a cycle with your partner, or donor sperm. So I had a cycle using egg donation. So again, was kind of living both sides of the coin as a nurse, working in that field, supporting patients, and as a patient myself. And that cycle was successful. I became pregnant, first time I'd been pregnant since trying. And that was when things started to change. A couple of weeks after that, I started to become really unwell. I developed a lot of different symptoms. I developed severe skin rashes, genital rashes, and swelling. I lost quite a lot of weight. I had gastric problems, skin problems, lots and lots of different symptoms, which were quite unusual, which continued to get worse and worse. I'd been back to the clinic, they'd changed my medication, I'd been to see various doctors, but unfortunately, I had to stop the medication because it was just basically something that was impacting on my life, and how I was feeling was becoming worse and worse. And then after I stopped the medication, unfortunately, I had a miscarriage, so
Oh.
pregnancy didn't sadly continue. And even at that point, I didn't really know what was happening. Wasn't really sure what had happened. My husband wasn't really sure. I had lots of experienced medics, also, very, we're not quite sure what's happened here. And it was only when I went to see a specialist that I was diagnosed with the rare condition progesterone hypersensitivity. So that was some months afterwards that I got diagnosed with that condition.
Wow. Can I ask you just a couple of questions? Thank you so much for being so open and so generous to share your experience. I mean, there's some really interesting timestamps there in that. Did you have any idea? I suppose my first question is, did you have any idea leading up? I mean, thinking, yeah, everything seems inverted commas normal for me. And then when you say the drug, I mean, what was that drug? So two parts to that, which would be really, really interesting. So can you sort of fill into us, were you blissfully unaware in the beginning, or were there little signs either retrospectively you can start to see?
I think in the beginning, I was blissfully unaware. I'd had taken progesterone before, as a lot of women have, as part of contraception. I'd
Mm.
had a Mirena coil in my 20s, which is a low dose of progesterone that's administered in the coil for contraception or problem periods, or a lot of ladies in the menopause will be using it for their progesterone HRT. I'd used progesterone in IVF cycles, as a lot of women do, and I hadn't really had any major problems. I think I'd had one inclination where I noticed some rashes, but it wasn't a great deal of things, and I never really made the association. That was in a previous, a natural cycle,
Mm,
natural period cycle. And I thought, well, just bad luck,
mm.
So yeah, I would have to say I was probably blissfully unaware until probably about 3 or 4 days. So in an IVF cycle, usually you'll take your pregnancy test a couple of weeks after you've had the embryo put back. So it was a few days after that that I'd started to notice the changes.
Wow. Wow. And when you say the drug that you appeared to be reacting to, what was that? Was that progesterone?
So the drug is progesterone. So in IVF cycles, and a lot of fertility treatments, they will give you hormones at certain points in your cycle, because often your body's been down-regulated or you've been taking other hormones. So they need to kind of replicate what would be expected to happen in a natural cycle. And as we know, for women after ovulation, we produce the hormone progesterone, prepares and supports the body for a pregnancy. And if we're pregnant, that hormone continues and takes over until eventually the placenta takes over in a pregnancy at about 10, 8 to 10 weeks. So yes, it was progesterone. It was progesterone medication, and the reason I say medication was because I tried several different drugs, different
Right.
types of progesterone, and all of them caused different reactions.
Yeah, so definitely a link correlating that you had
Yes.
a sensitivity to that. And so obviously, so medics are quite bewildered, not really knowing what to do. How did you then sort of, with your specialist? I mean, would you mind me asking how old you were at that
No, not
stage,
at all. I
Kay?
think I was 36 at that time. So I'd been diagnosed with POI, I think a couple of years before. I'd then waited to have egg donation. I'd then kind of followed treatment plans. So yeah, I was 36 at that point. After it had all happened, I spent a little bit of time just not doing anything and kind of getting your head around it. And it
Mm.
was one of my dear friends and colleagues who said, "Well, actually, I think you need to find out a little bit more about what's happened here, because you can't just not know." And that was when I
Yeah.
started to think, right, okay, who should I go and see? What should I do? And then I started to kind of put my practitioner hat on and start investigating and asking the questions.
Yeah, I love that because that's you're a girl after my own heart because that's the thing. We need answers, don't we? So we sort of go back to what we know and ask those searching questions. And so from your perspective then, I mean it'd be really helpful if we could just sort of just back a little bit to help people understand how does POI, primary ovarian insufficiency, how does that come about? Is that something we're doing to ourselves? What is it actually relating to when we use that term?
So we use the term primary ovarian insufficiency, or POI, when we talk about women under the age of 40 who experience, it's a condition where your ovaries stop functioning and don't function as they should. And then women start to experience menopause symptoms. Now, we often also use the term premature menopause because sometimes a lot of people understandably won't have heard of the term POI. So often when I'm first explaining it to patients or friends, colleagues, members of the public, I'll often say the term premature menopause so that they start to understand what it is we're talking about. But the actual technical term is premature ovarian insufficiency. So we're talking about women who experience menopause symptoms and their ovaries not functioning as they should before the age of 40. So you can have women in your teens, 20s, 30s who experience this. They think it's about 3.5% of the population, so kind of the prevalence. And obviously, the younger you are, the less likely it is, but it certainly does happen. I know several wonderful women in the POI community who were diagnosed in their teens. But the kind of statistics would be 1 in 100 under the age of 40, 1 in 1,000 under the age of 30, and 1 in 10,000 under the age of 20.
Wow. Yeah, so that's really powerful, isn't it? Because someone asked me on a podcast recently about, is there a sort of standard definition of menopause? And I went, no. There isn't. So that makes it nice and easy, doesn't it? And actually, that's why it's even more important to broaden our gaze in this conversation to think about younger generations, and actually those teenagers that we know, and checking in on them, are they menstruating? Are their cycles some sort of regularity? I mean, we know it takes time for the reproductive system to mature, but it's so, so important. Can you tell people why it's so important, Kate, to
It,
not just go, blissfully on with your life and why you should get checked out.
It's really important for a number of reasons. So often people might say, well, POI is the same as menopause. Yes, patients experience menopause symptoms, and we'll come back to that. But actually, we have to think about this group of patients very differently. They're impacted in a number of ways. Key thing is on their long-term health. So if you're below the age of 40 and you're not having hormones that your body should be having, then that gives you long-term risks such as cardiovascular risk, osteoporosis, so impact on your bones, cognitive impact. There's also the impact on fertility. So we're not saying that a natural pregnancy isn't possible for a woman with POI, because the ovaries don't fully, close the door, but it's much, much lower at about 5%. So it's counselling these patients that the impact on their fertility, the impact on their long-term health, but also the impact of experiencing menopause symptoms. A lot of us can think about menopause symptoms, but my question would be, imagine having those symptoms if you were in your teens or 20s. Imagine being at school or college and having vasomotor symptoms, vaginal dryness, cognitive symptoms. So, and it's also understanding this as not just a short-term condition, but a condition that impacts both in the short term and the long term.
Yeah, I love that definition. That's just so powerful, isn't it? Because so much of it is unseen.
Yeah,
I used to sell blood pressure medication when I was a rep in the pharmaceutical industry, and of course, it's asymptomatic largely.
yeah, totally.
For the vast majority, unless you get like pulsing headaches, most people have no idea they've got raised blood
Yeah,
pressure. It's only when
yeah,
we look at the end points that we go, yeah, someone was trickling along with a high systolic
yeah,
blood
yeah.
pressure. So it's really important. I mean, from my own curiosity as well, and I'm sure I speak for many people because we do talk about this in our own sessions, but when we think about it, then so in the ovaries, is it that we're not getting follicles forming? Do we actually know what is the mechanism by which there is an issue in primary
So
ovarian
there's lots of
insufficiency?
different schools of thoughts when we look at POI. So when we say, "Oh, what do we think the causes are?" The first is that there's the possibility that if we think about a woman's ovarian reserve, or what we're born with as baby girls, we imagine, this full jar of Smarties with millions of eggs. But actually, some individuals might be born with a much lower reserve, hence
Mm.
less eggs to use in the journey. Sometimes there's a school of thought that the way that they respond, the eggs respond and grow, may be different in this group of patients. We know that there is a big genetic factor. So if I'm seeing patients for consultation with POI, I'll ask them very closely, do you have any family members, cousins, aunts, sisters, mothers, grandmothers? Because we know that it's not a dead
Mm.
cert, but it's highly important and can be really, really relevant. I only saw a patient literally last week in that situation where she'd identified a family member. So we know that there is that family link, familial link.
Wow.
We also know that there can be genetic conditions such as Fragile X syndrome, Turner syndrome, that mean women are more likely to have POI. Rarities, there can be some infections and other causes. Also, if a woman is having surgery or treatment for cancer, we know that chemotherapy is toxic on the ovaries, so this group of patients would likely also experience POI. But if we're honest, then we would say that the greatest number of patients that have POI are what we call idiopathic POI, and this means that at the moment we can't say exactly what the cause was.
And that's so powerful, isn't it? I mean, I'm constantly fascinated, first of all, about, that whole evolution of our eggs and our ovaries and how much sort of natural discarding takes place before we even
Yes,
exit the
huge, yeah.
womb. And then there's this constant sort of culling, isn't there? And follicles not coming to maturation, and then they get reabsorbed. So my understanding also is by the time most of us get to menopause, we've got, when we're not getting that menstrual cycle, and by definition we haven't had a menstrual cycle for a year, we might be down to about 1,000 eggs.
And that sounds a lot, but it actually isn't if you think that we started on average as a baby girl with maybe 1 to 2 million.
No, it's just inconceivable, isn't it? It is, 1 to 2 million. We sort of think there's plenty there. We'll be
Plenty
fine.
there, no problem. But
Yeah.
we're losing eggs as for women, even women without POI, we're losing eggs as we age, we're losing eggs as part of our menstrual cycle, and there isn't a single treatment apart from egg freezing that is preventative for that. So there's lots of fertility treatments, but there isn't anything that can impact on the age of the egg, apart from if you say, oh, I froze my eggs at 30, I'm going to use them at 40. There are no, people often think that IVF is the answer, not necessarily for this condition.
No. And do we know anything, put you on the spot, is there any sort of correlation to our levels of stress and anything like that. I mean, because I think it's just, we maybe don't make those connections. I mean, I don't know, there might not be. I mean, what do you think? I mean, in terms of stress, lifestyle, could that be impacting for people also?
I would say we don't have any evidence to suggest that it is, but I would also say on my other hand that there's so little research in this area that we probably don't know enough. Now we know women get pregnant in war zones, have children in very stressful circumstances. We
Yeah.
know that. So I would say I would probably be sitting on the fence at the moment saying, well, we don't have any evidence to say if you're really stressed, that means that you'll get a particular condition, but it would be great if we could do some more research.
Yes, I'm going to make a note of that. That is so, so powerful because that is part of the problem. We need more research, don't we?
Totally,
We need to
totally.
connect the dots more on this. So coming back to the progesterone, this is brilliant. I could talk to you for hours. So coming back to the progesterone side of it, how do you, I mean, if you were to hypothesize, obviously you were living with your own progesterone for some time, quite, unproblematic in that way, and then it became problematic. I mean, do we understand that mechanism? What is there a type of switching over? I mean, I certainly know in my own experience, Kate, having had estrogen dominance, I became really, really sensitive to my own estrogen. So then I then had something called histamine intolerance.
Yes.
So I have to be very careful about tinkering around with my estrogen. Actually, more for me, I'm way more concerned about getting a good dose of progesterone because that sort of cancels out the effect of estrogen. So I'm always watching my histamine. Is there anything you can tell us about that then experience? Because it's almost as like you weren't showing signs necessarily of being very sensitive to progesterone, and then you were. Do we know anything about that?
So I do talk about this in my book. It's amazing that you think, well, looking back, could I have predicted this? Could I have changed
Mm,
it? And having a conversation with a specialist, we did look at my history, and I never really had a normal, what I'd say would be a normal period. Even before I went
right.
into nursing, I think I was in my mid-20s when I went into nursing. I'd be amazed at these women who knew when their period was and who knew, roughly how long it was. That never really happened for me. They were
Oh,
always
okay.
irregular. They were always very, very different, either really far apart or really close together. So one of the theories was that obviously perhaps I didn't, it's only a theory, but perhaps I didn't ovulate that often, or I hadn't had a high exposure regularly to progesterone. I did have a Marina call in my 20s for precisely that, because I went into nursing and said, well, there's no way I can navigate significant period problems while, working with looking after patients.
Mm.
So there's no actual answer, but hindsight and the detective in me thinks, well, was that possibly a sign? Possibly.
Yeah, and that's so interesting, isn't it? Because um, I've worked with some individuals sort of recently whereby sort of looking, certainly when you get heavy menstrual bleeding, we know you're getting a fairly hefty sort of response to your own estrogen. And we see that, don't we, more in perimenopause, whereby that menorrhagia starts because actually the ratios are changing. And I
Yes.
suppose what you're saying there is actually your ratios may have been changing sooner and for longer over your life course, and so therefore then your ratios would be quite different to somebody else. I mean it's absolutely fascinating, but a call for more research is definitely so important. So let's tell us a little bit about you, because it sounds to me like you've taken, there's no doubt about it, incredibly difficult situation. I mean, talk to us about the impact on families, if you don't mind. You mean in your wonderful book you talk about the impact on people also, not just the individual, but around like our partners, our families, our friends. Can you share with us what you noted and what you documented so beautifully in your book about that response or that interaction with people?
Yeah, I mean, I think if I looking back, obviously if I look at my own circumstances, my husband and I we saw a specialist because at that point, after I'd had the pregnancy loss, we did have an embryo still in storage, so we were debating what would that mean for us. So we did see a specialist, but it was our decision to kind of stop treatment there and not continue. So we did donate our embryo to research because of the really just the unknown and the symptoms, and then kind of thinking, well, would we want to go through that again? Because it's a lot both. It was a lot both for me recovering. It wasn't that you kind of recovered the next month. It probably took 6, 8 months, possibly longer, to kind of recover. There wasn't really anyone. My friends were incredibly supportive, but there wasn't really anyone I could speak to who had a similar experience with the condition. There may be women out there. If there are women out there, you're not alone. But I suspect it's a very small number. So it was very much kind of navigating that path day to day, living in the moment, and focusing on what you could, you know, what symptoms you could kind of target and work to solve, and then deciding that long term path.
Yeah, and it's so powerful, isn't it? Because, like you say, I think it's important that workplaces understand this, that, it's significant, and we have so much more work to do about educating organizations so that there is that compassionate leadership, so that there is that support network that can wrap around people, be it a peer-to-peer support,
Yeah.
something covered in people's occupational health or employee assistance programs. This is happening to people, and it's not insignificant numbers. So it's really, really important. I mean, how has that sort of then steered you through your PhD then, Kate? How has that sort of impacted
So
your thoughts?
so I decided after we'd made our decision, I decided over time that it would be good to look at a new path. I'd felt obviously what you experience, what everyone experiences, changes as a person as we grow. So I decided it was time to sort of look at a new path and challenge myself in different ways and look to think, well, where would I go next? And I kind of had parked for many years. I'd run an egg donation program where I'd looked after a lot of women who had POI before my own diagnosis. And what that meant was they were waiting on the egg donation list for egg donor eggs. And often there was a waiting list because you're asking for a woman to come forward to donate her eggs to give you a chance of having a family. It's a gift whether, of huge impact, and that you're waiting for. So I looked after this group of patients, and often I would speak to them and say, oh, when do you see your healthcare professional, or do you have any support? And a lot of them would say, no, I don't really see anyone, I just take my HRT and that's it. So for a long time I'd always parked and thought, I feel this group of patients has a lot to say
Mm.
and no one's really asked them. And coincidentally, I happened to find a centre for study at De Montfort University, the Centre for Reproductive Research, and I thought, this is somewhere I'd like to study. And I'd
Oh.
just finished my master's and was full of joy and excitement, and stupidly thought, I'll send in an application. No, it won't go anywhere. It'll be all right. And of course, they were delighted. I'm not quite sure what they've realised what they've taken on. The reluctant academic who doesn't really
Yeah.
like academic writing but likes to talk. Um,
Yeah, if only we could just talk our way through our
just talk
PhD.
our way through it.
I
That'll do
know.
it.
We'd be fine.
We'd be fine. It's that's what patients want to hear. So
Yeah.
I really felt that this group of patients had a lot to say. And then when I conducted the literature review, there was some research, but a lot of it was 20 plus years ago.
Okay.
And if you wanted to look at POI in the medical sense, what does it mean? What's the treatment? What's the medical plan? Yeah, loads. But if you want to ask a person with POI what it's like to live with POI and what their experiences are, not so much recent data on that.
No. And that's the bit that's not fit for purpose then, is it? If people can't see themselves in the research, that I think that's the most demoralizing part of it
Yeah,
all.
totally,
I mean, I
totally.
never saw myself, and in any of the research, I'm from the South Asian community. I've got
Yeah,
complex genetics, clearly, and at 36 with a 2-year-old, I didn't look like your typical perimenopausal person. So it's really important that the research is robust. I am delighted to say there are so many more universities picking up women's health topics and
totally.
research.
Yeah.
It's just, I mean, it's now's our time, Kate, definitely. So when you think about that then, where was the catalyst for Progesterone and Me, your book, which is, by the way, coming out on the 13th of March for people, and you can pre-order it. So what was the catalyst or the spark that thought,
I
I'm going to do
happened
that?
to be talking to a friend and I just said to her, oh, I've written a few things down about what happened to me. And she said, oh, right, okay. And I said, I'm not really sure what to do with it. So I'd started to do it a bit cathartically. And it was partly because I'm really fortunate to have an excellent team of supervisors for my PhD. And one of the things that we'd looked at early on was juggling the hats that I was wearing. I was a researcher, I was a women's health nurse who worked with POI patients, but I was also a POI patient. So
Yeah.
we spent a lot of time dissecting that and thinking about how that will, and we still do, how that will impact the research. And I didn't want it to be my research. I wanted it to be the research of the women that come to me. It's about them having their voices heard. So we've done quite a lot of work and exploring, what that would mean for me, in which hat would I use at what point. And one of the things I sat there and thought was, well, maybe I'll just write down a few things to be cathartic, because we talked about reflexivity, and I talked about in my ethics application about how I was going to do that with a reflective journal. And I wasn't really a journaler at that point, and I thought, yeah, I'll write it down. And then on the other hand, if I thought, yeah, best write it down now, because the amount of things you forget, you'll probably forget all these really important things that someone
Yeah.
asks you, and I'll just look at them blankly and go,
Yeah.
maybe that happened. So I started to write it, and it's probably quite easy to write about yourself, isn't it? It's easy to write about something that's happened to you in some ways, in a way, in a digest that most people can read and understand. So it isn't an academic book. It's just written in a way, because as nurses we're so used to taking complex information and talking about it in a way that everybody understands, because we want to make sure patients know what's going to happen. So I just started to write it, and I happened to talk to my friend. She went, "Oh, why don't you just publish it?" And I was like, "Who's going to want to read that?
Oh.
Who's going to want to strap in for that?" She said, "Well, you never know." So I just, and again, I'm like lots of us. I'm not a celebrity, don't have millions of followers. I thought I'll send it off to a small publisher, see what they say, and not worry about it. So
Yeah.
I sent it away. Never thought about it, and I happened to be at the airport because I do some work in Ireland, and got this ping saying we'd be interested, and I was like,
Wow.
"Righty, okay."
What did you feel in that moment?
I felt quite emotional actually. You kind of feel a little bit validated, because
Yeah.
we all talk about, whether would we share our story, would we do it, and I ummed and ahed because it is a personal story. But I thought, what if there's someone else out there who
Yes.
might have gone through the same thing, or is going through the same thing? What if you could help them not sit in their bedroom like I did, trailing through articles or information, looking for anything that might sum up or explain what it was that happened.
Oh, yeah. And that's the most wonderful thing, isn't it? Because one thing that I'm becoming acutely aware of is the power of conversation.
Yeah,
Even by proxy, you might be earwigging to someone's conversation. It can be incredibly impactful. I've heard lots of amazing conversations sat in tube stations,
oh, totally.
service stations, and you sort of think, I'm always like that person. My husband says, please don't go and interrupt them and tell them you've got something helpful for them, because the temptation is, I don't like the thought of people suffering, and I do genuinely think people are suffering because they don't know where to go for information. And I think I love the fact that you've told it through that lens of storytelling, and your PhD will capture those narratives, because so many of us don't feel like we're validated, seen, heard. And that does trickle into the workplace. We see women stepping back, stepping down, stepping out of the
Yeah, yeah.
workplace. That has a huge knock-on effect on the family unit, on relationships, on how we see ourselves, and I think how we then move forward in our lives. And we're living longer. It is possible to have,
And I think some of
a
the things I uncovered in my reading about progesterone was that it could be something that might increase in the future, because, as you say, there's more of us. There's more people having fertility treatment at different stages in their lives. There's more of us taking different types of contraception, and that's not a bad thing, because for most of us, if we find something that works for us, that's really, really important, and we should be following advice and what we want to do. But it could just be that it might be something that I'm not wishing that on anyone, but if someone else experiences it, then there's some information out there.
Yeah, and I think that's really powerful. I did a podcast with an influencer, Chloe Delolio, and it was about generational conversations. And she said up until I'd asked her that question, she'd never ever spoken to her mum about menstrual health at
Yeah,
all. And so I think you and I are in a bit of a bubble, aren't we? Because we sort of move in circles where that's all we talk about.
yeah,
And the
yeah,
reality is, for so many people, it's like, well, no, we're not talking about that. Certainly not in the transgender community, or,
yeah,
same-sex
yeah.
relationships. How many people are talking? I mean, it's not impossible that you couldn't have two people who are potentially going through POI, fertility, and actually trying to navigate that alongside either perimenopause or postmenopause. I mean, you could have the whole lot circling at any one time. So it is really, really important. I mean, I can't wait to read your book, because I know that lived perspective is so, so powerful. So let's just move on then to ask a little bit more about then. So when you think about, let's say we have got someone who's either using a tracker app, Kate, and there are many great ones out there. Do you have any personal preferences for tracker apps?
I don't. I know there are a lot out there. I'm really, really keen to. I would never say to a patient, don't use that, but I'm keen to educate patients about what's good about them and the limitations so that they
Tell
can
us
understand.
then, tell us then, what's good about them for people who maybe aren't using them and just using a paper calendar? What is
So
good about them?
I mean, you can have it on your phone right there where you need it, where we're living all our lives. So,
Yeah.
you can, and often you kind of see the front end of these apps that are really whiz bang and exciting, but the back end, how they think, a lot of them are very similar. So it's understanding what you see on the front end might not be what it's thinking on the back end. And
No.
obviously, it's also understanding how they work. So that often they will look at your previous cycles to predict what's happening. So I think it's going in with an open mind and not kind of seeing it as something that's thinking and all seeing eye, but actually it's a good way of recording things and it's a good way of looking back over cycles. It's a good way to have something if you're at a consultation with a healthcare professional to say, oh, these are my last 3 cycles. So I'd say, okay, what's happened? How long was there? How many days did your period last? Was it painful, heavy? Did you get any
Yes.
bleeding in between your cycles? So we're not necessarily saying, well, it's going to predict when my period is, but looking back at the data can be really, really useful.
I think it's fantastic. All I had available to me was an Excel spreadsheet, Kate, and I took great delight in taking 36 months of data in. Can you imagine? I've just plotted
But
this
but
out for you, Doctor. Very luckily,
But do you know
last
what?
month.
If you don't want to have it, that's fine as well. I'll often say to patients, if you want an old fashioned diary, do that. Do that.
Exactly. And I've shared before, my daughter did her A levels, and then her menstrual cycle was missing in action for 5 months. And we were like, okay, right. I mean, logically, I was thinking it's got to be stress related. It's got to be stress
Yeah, yeah,
related. But
yeah.
we did go after three. I mean, I looked at all the research, but she was great. She already had her period tracking app, and we could see that actually, you know what, she was definitely showing a shorter cycle, it was getting shorter and shorter and shorter, and then it just stopped. But then she went on holiday after her A levels, all the rest of it, and then it turned back up. But
Yeah,
because of the stress, it's taking longer to elongate. But actually, she celebrated having, like, a much longer cycle just recently. I think it's important to know it's just some of those backstop rules, really, that actually, if your period suddenly disappears, that is a point to a
absolutely,
red flag, isn't
absolutely.
it? It's like we should be addressing that and having a talk and a chat with someone who will be able to reassure you. And also we should say that, like any bleeding, and I think it's so important to remind people all the time, if you are postmenopausal, so you haven't had a bleed, any bleeding, please do get that checked out. It goes the
Yeah,
other way as well.
and as healthcare professionals, we're very used to it. So a lady coming and saying, I've noticed a change in my period, don't feel that you're kind of troubling us or it's a problem. It's not a problem at all because we can talk about what was normal for you, where you're at, what's happening, and then we can talk about what we want to do. So if you're a lady who's postmenopausal, you haven't had a bleed for 3 years and then suddenly something's turned up, we've got pathways for that. Even in our
Yeah,
wonderful, very stress busy NHS, we have pathways for that. If you're a young patient, perhaps like your daughter, we've got, we can look at blood tests or scans. So we can usually
exactly.
suggest a plan of action and think about your period as a sign of, your overall health. So if you're 25 and all of a sudden your period disappears, well, why? Have you lost a lot of weight recently? Are you doing a lot of
Exactly.
exercise? Is there something else going on? Have you started medication?
Yeah, oh yeah, it's so powerful, isn't it? And actually stepping forward, it's really it's a powerful mandate for yourself, definitely. So yeah, apps are a great way forward. So when we think about then, I mean, you've obviously been in this environment for quite some time, Kate, and you'll have seen great practice, not so great practice, opportunities to do it differently or do it better. I mean, what changes systemically within our sort of environment are needed to better support women and those with female biology or who identify as female at birth? What more can we be doing, do you think?
I think a lot of it comes down to education. This is
Mm,
This is no criticism of any fellow healthcare professionals, but a lot of it comes down to education and knowledge. We need to prioritise women's health and education, both in medics, nurses training, and other healthcare professionals. It's so important. We're 51% of the population. If we can prioritise women's health education and training from the get-go, this is going to be much better for patients coming forward, because we will be, even if you're just aware of the basics, a GP covers everything. That's amazing. They're a generalist. They cover everything from, oh, I've got someone with period problems in, then I've got someone with high blood pressure, or I've got a child with an infection. They do all of that, which is fantastic. But if they have a bit of education in women's health, they'll know how to signpost, how to review, what to look for. And I think listening to our patients, you're the expert on you. So, traditionally, we perhaps didn't think in that way in the medical model. We were the clinician, we had the knowledge, we had the information. But actually, you're the patient, you're the expert on you. You have the information and the expertise on what's happening with you at this moment in time. So I think we cannot underestimate taking time to listen and communicate with our patients. And there's nothing wrong with saying to a patient, okay, I've documented everything, but I think I'm going to refer you here or do this. There's nothing wrong with explaining our limitations, because as practitioners, no one knows everything. It's also having the honesty and transparency to say, right, let's do this, or let's go here. But we can't underestimate how many patients are still not listened to or dismissed when we're talking about women's health issues.
Yeah, that's so true. And I think, the patient's charter still exists. It is your right to ask to be referred. And so, we will put some resources up for people. I mean, are there any specific places that you would direct people looking to get more information, either about POI or fertility, that we can sort of signpost to people now and then we'll put in the show notes?
So I often, if I see a patient that I suspect it might be a diagnosis of POI, I'll refer them to the European Society for Human Reproductive and Embryology, ESHRE POI guidelines. They're an excellent resource. They've just been updated by Nick Panay and his team. But this is a fantastic resource for both patients and healthcare professionals. And I'll often say to patients, well, just take this link with you and pass it along to your GP or whoever you're seeing. And they'll say, oh, I can't do that. Of course you can. They'll be grateful. If they don't know about it, they'll be really grateful. They'll think,
Yeah.
great, I'll have a look at this later. Excellent, thank you.
Yeah.
So, it gives you in a really easy, understandable way of what tests need to be done, what needs to be looked at. For POI, the DAISY network is a fantastic resource. They are the charity and support for POI, and also myself and three other colleagues, we all happen to work in the medical field. We set up our own POI podcast called the Premature Menocast. So it's a small but perfectly formed podcast where we just explore what it's like. We're all healthcare professionals who have a diagnosis of POI. So we explore, various things that might come along in diagnosis, management, and living with POI.
Brilliant.
Because we didn't know, we couldn't find anything else out there. Yeah, there'd be the odd episode on podcasts, which was great, but there was nothing really with anyone experiencing it.
Yeah, that's lovely. The Premature Menocast, is that
The
right?
Premature Menocast, we gave it that name because we wanted to kind of have a name that explained it, that everyone would understand. And also the POI podcast was taken. Who'd have thought POI and points of interest? Who knew?
Oh my goodness, yes, exactly. Exactly. Well, those are great. And I think it's always worth saying to people, really be careful where you do consume your information. Go to those reputable sources, places where there's a very strong evidence base. You just prompted me to think, I've seen today multiple people on social media advertising, take this, you'll lose weight, take this, it'll boost your muscle. There's a lot of product placement and promotion, and even the other week I had to sort of like signpost to people constantly talking about creatine. Actually, not everyone can take creatine, especially if you're on ibuprofen or aspirin. Can cause kidney problems. So when we think about our sex hormones, we know we can have phytoestrogens and things which are weak versions of estrogen, but am I right in saying there is no food source that replaces progesterone? I mean, I know yams in Africa, and then obviously through a clever pathway they make progesterone that's in our NHS progesterone.
The lovely scientists in the lab do all of that, and
which is amazing, isn't it? It's from a food source. But I'm right in saying there is nothing that you can take that's going to, in your blood levels, up your levels of progesterone, is there?
No, not that, certainly nothing that I know. As you say, phytoestrogens, we talk about that a lot when we're thinking about menopause or diet, and often they're foods that are really good for you anyway. So there wouldn't be generally a reason you'd be avoiding them unless there was a specific medical reason.
Yeah.
There isn't anything that can change in terms of progesterone. So, and I suppose the important thing is when we're looking at a progesterone sensitivity, you can have a sensitivity to your own hormone or a progestin, which is a hormone, is the hormone that you take in the form of a medication. It could be a sensitivity to that hormone. And I think the key thing to take away is that it varies. So they, like anything, like the dial in your car, there might be some women who have some reaction to progesterone. So the most sort of common suspects that we know about, think about when we're in the luteal phase of our cycle, we often experience changes in bowel movements. Perhaps we become a little bit more constipated because of the progesterone impact. We might feel bloated or breast pain. These are, as you say, often manageable side effects. But when we're looking at a progesterone sensitivity, they often used to call it progesterone autoimmune dermatitis before they gave it the new
Right.
exciting name because of the changes in the skin. So you might see some patients who always had developed rashes in the luteal phase of their cycle. So sometimes there can be a cyclical component in your history taking where the patient says, yes, it's always at this point in my cycle. Okay, detective brain going in. What's
Yeah.
going on there?
Yeah.
Or, as you say, it could be something where it's the medication that you've taken, or something often there isn't as much research. If we get more research, we'll certainly find out more. We don't think, in my most recent reading, we don't think that there is a familial disorder, but again, we need to know more. And often it can be difficult to make the diagnosis because symptoms can vary, because you might have periodic symptoms, or you might have symptoms coming a few days after you'd started the medication, for example. So I think what's key is the skill of the healthcare professional, or referring to those appropriate experts for help.
Yeah, no, that's amazing. And it's probably, I mean, there is more and more research coming out because we know that our sex hormones also interact with our neurotransmitters. So I
Yes.
think, like you say, we'll have better questioning going forward. I mean, it's amazing. If I were to sort of bring things to a close, doesn't time go quick? When you're talking about the things that you love and want to get better education on. I mean, when you think about what's your hope for the future, Kate, crystal ball gaze another at least even 5 years from now, what would your hope be for people who are experiencing POI or in terms of the research going on? What would you hope for?
I would, if someone gave me the magic wand, I would want more research. I know I'm greedy and I'm demanding, but I think there needs to be more research and more support for these group of patients. It's very much fragmented, so perhaps the patient's seen and diagnosed and then they're reviewed for their HRT, understandably, or their fertility options. But it's not just about HRT and fertility options for POI, it's about supporting women to live with the condition. So there very much needs to be a wraparound ongoing support, psychotherapy, dietitian, impact on long-term health, cardiovascular monitoring, for example. So I think in 5 years' time, what I'd love to see is that wraparound care. At the moment, there are some fantastic individuals in this space doing fantastic work, but there's not enough of us. There's not enough specialist clinics. And we need to think not just at the point of diagnosis, how we talk to our patients, how we give the diagnosis, but how do we support them? Because if you're 25 with POI, hopefully you're going to live, how much longer are you going to live? 50, 60, 70 years?
Hmm?
We must be supporting these patients with that wraparound care throughout their lives to help them live the best life they can.
Definitely. I mean, and if I were to sort of say to you, I mean, are there centres that people can look into, like obviously for patient referral? I mean, we know, for example, UCLH is, my sister went there for her endometriosis
Yes.
care. And I recommend to most people, I say, if you really want to go to a specialist centre, it's a bit like taking your car. You can take it to any old garage, or you can take it to the garage that actually is your garage, like, for the brand of car that you're using. Is there any way you recommend that people could either do their own research? Is there a centre of excellence for POI in the UK?
There isn't a centre of excellence as such, but you're absolutely right. There are some really good clinics, the Chelsea and Westminster in London. There's obviously generally what will happen is that if you're going via your GP, if they follow the guidelines, will make a referral to secondary care, which is the
Yeah.
hospital. Now, some clinics within secondary care, depending on where you live, will have a POI clinic. So we've talked about a couple of
Mm.
clinics in London. Birmingham Women's has a very good clinic. I suspect there's probably a good clinic up in Liverpool Women's.
Mm.
So there will be some centres already, but there's only a small number of these clinics. So a lot of patients will probably get referred to the menopause clinic under gynecology, which is a
Right.
great starting point.
Yeah.
But we also must remember that you as a patient, if you don't feel that's the right space for you, you can then say, right, I'd like to be referred to the specialist centre for POI. But what we're juggling realistically at the moment is our wonderful NHS is under significant pressure and waiting times are extremely high. So I think if you're listening to this and you have POI, I think you need to be looking at, well, what treatment do I need to be starting sooner rather than later? With
Mm.
HRT, for example, for menopause at the expected age, this is a choice. But for women with POI, individuals with POI, it's very much a gold standard. We want to be looking at some form of hormonal replacement if you're able to take it. And this should be something that needs to be started sooner or later. So perhaps that could be via your GP with support from the clinic until you see someone. But know that there's lots of options and ask questions and reach out to the POI community via the Daisy Network, our podcast, the Instagram community, so that you're not alone.
Yeah, sage advice. That's so, so important. I suppose what we're saying is you're not alone.
No, totally.
You're not alone. And there are people who care deeply and who have gone to the trouble of writing books so that you can shortcut that whole navigational piece. And I think that's so important for people because that's the bit that really grinds you down, isn't it? Like waiting, trying to keep going, trying to keep going, trying to find the next solution. Because that's naturally, I think, how women are. We're solutions focused.
We
So,
are, yeah.
so I think that's wonderful. Wraparound care. So as we finish up, tell us about the book then. Where can we get it? I mean, hats off for self-publishing. I'm in total awe of anybody. I remember Diane Dancebrink saying to me, I'd never do it again. She said, because you need to,
She
she said,
will. I know
you need to
Diane.
give,
She'll
yeah,
have an
yeah,
idea up her
yeah,
sleeve.
yeah. She
She's
said,
probably
you need
thinking
to
about
give,
it now.
yeah, you need to give it 6 months. She said to me, Amantha, give up your job. Give them over 6 months to do it. But tell us, where can people get it? Where can they get their hands on it? Over to you.
So first of all, I'm really delighted to say it isn't a long read. In fact, I'm checking the page number right now, and I can tell you, I promise you, it's 154 pages. So it's something that you can carry around and not feel that you've got a brick in your bag. Because I
Yeah,
often buy lots of books and I intend to read them all, and then I don't.
no.
But it talks about the interweaving of being a fertility nurse, working in women's health, and my path from then going into research, menopause, and a new path navigating a life without children. It talks about the fertility journey. There's a little bit about POI in there, and yeah, if anyone fancies a read, no pressure. If you live in locally to me in Harwich, there's going to be one in the library there because I'm always keen to put one in my local area.
Lovely.
And I understand Dublin City University, where I work, have also got one in the library there. But otherwise, I'm pleased to say you can either order at Olympia Publishing or easy peasy, just write progesterone and me in Amazon. And my mum texted me, was it last week? And all I got was, "You're on Amazon." And I'm like, sorry, what? What's
Brilliant.
going on? I had
Brilliant.
no idea. No, I don't know how my mum had
You are,
even.
I can confirm you are on Amazon. Your mum's
But I
right.
am on Amazon. So
You
yeah, my mum
are.
sent me this text. You're on Amazon. She said, "I've ordered one." I said, "You don't need to order one. I've got one
Oh,
here."
oh
"No, I
no, but
want
she
it to
wants to
arrive in the
support you.
box."
Yeah, your mum's going to do an unboxing. How
Yeah, there's
brilliant.
going to be this video of the
Yeah.
book being unboxed in Amazon. So yes, it is on Amazon. I'm getting my head around that. I need to tell people about the book and not say, "Here's a book, run away." So have
Yeah,
the
no,
confidence
you
to
really
say,
do need to tell
"Would you
people,
like to read it?"
here's a book. I intend to take your book. I'm starting my own women's circle in
Ooh.
Devon. And I intend to do book reviews. So you will be there. So we will, and it's an independent bookshop is where we're gathering as a women's circle. So to be surrounded by knowledge,
Well,
sharing
that's my next
knowledge.
step to have the yeah. I mean, people say, "Oh, what do you mean you're shy?" I'm great at talking about my favourite things, but I'm going to make myself this week, because I've got a day off, go to Colchester and go into Waterstones and tell them about my book. I'll be terrified. It'll be
Definitely.
like the worst job interview ever.
Oh, well, and you know what? If you do, what you should also do is what Ginty and Lou from Womenkind Collective
Oh,
do
I love
a
Gin.
bit of book guerrillaing, and go and literally position your own book there, and then once it's stocked.
Oh my God, I never thought of that.
Oh no,
Right.
listen, I need to help you. I need to
You need
help
to
you do
help
a
me
bit
because
of
my
gorillering.
sister just looks at me and goes, "What are you doing?" And I'm like, "I'm not doing anything." And she's like, you need to be telling people." I'm like, "They already know." And she's like, "They don't."
No, and that's why it was so wonderful when I saw your post on LinkedIn. I thought that could be a wonderful way to let people know, you know, blurt the message out there that this wonderful book is available. You're available. And where can people find you, Kate? Because why wouldn't they want to know more about what you
If they
do?
fancy seeing the calamities of Kate juggling the hats, I'm on Instagram, which is at fertility underscore menopause underscore supports. I often post about POI, women's health issues, nurse education, menopause, and yeah, really what calamities are going on in my life. You know, like last week, the excitement on the story was falling over on the way to the airport in Ireland and someone stopping their car to help. So
Oh my
I was
gosh, are you
inundated with messages saying,
okay? Did you hurt
yeah,
yourself?
I bounce really well, but I got all these lovely messages. Are you all right? What's happened? But I was just saying how wonderful are people in Ireland that get out their car to help you.
I know. Do you know what? There's so much wrong in the world right now, but there's also so much that's so good,
There
isn't
is,
there? There really
totally.
is. If we look even just a little bit, we'll see those glimmers that humanity is still
It's
okay. There
still
are some,
there,
it's
totally.
still there. So we'll celebrate. So you're on LinkedIn and at fertility underscore menopause underscore support website is there as well. So we'll put all of these details in your show notes. But I just want to say from me to you, thank you so much. I know how incredibly busy you are, what great work you're doing. And actually, you're someone that I also see that has largely taken what was a painful part of life and you have turned it into your power. And I think actually that's quite a nice mandate for people going forward anyway, isn't it? You know, we're so much more than just the things that happen to us, and we can do whatever we want. So for now, thank you so much, Kate. It's been great to have you.
Pleasure, Amantha. Thank you for having me, and thank you everyone for listening.
Thank you.